Hi, so we are going to talk about certain diseases of the liver, more or less, uh, and relate them to a case. So I'm going to give a case scenario, and we will look into the disease, try to figure out what has gone wrong in that particular case. Okay, so let's see. Okay, uh, so let's take the first case. Okay, there's a patient. He is around 20 years old or 20 to 28 years, anything. He comes with severe bleeding. Okay, severe bleeding. Okay, he also has a little bit of tremors. Okay, plus certain amount of disorientation. Okay, uh, he's having certain amount of pain in the right quadrant. Okay, and this is about it. This is his symptoms. What do? You check for PT-PDT. All right, it's elevated. Okay, so PT-PDT is elevated. That means there's definitely a problem in the coagulation factors. Okay, so also you do a proper neurological examination, and you find out that he is disoriented. So that's obviously trying to hint towards you that there could be an hepatic encephalopathy. So there could be hepatic encephalopathy. And second is that you also want to think in terms of the pain in the right quadrant. So you do a palpation in the right quadrant, and you definitely see certain amount of hepatomegaly, or you actually see more of a splenomegaly. Anyone, you might not. It's not necessary. Obviously, uh, this might be completely absent as well. But definitely there is pain in the right quadrant. This may or may not be there. Hepatosplenomegaly may or may not be there. You ask the duration of the symptoms, and the duration is less than 6 weeks. Less than 26 weeks or 6 months. Okay, so it's been in 6 months that this entire thing has progressed, and this has been pretty much severe. Then you check for his icterus. Icterus is positive. Which is definitely indicative of jaundice. Okay, uh, you do a CBC. Your CBC count, your albumin is very low. It's less than 3.5, almost reaching up to 2. That's pretty much what it says about the entire thing. So obviously, without a doubt, your bilirubin. You check for your bilirubin. You check for unconjugated bilirubin. Okay, you check for unconjugated bilirubin. It's elevated. It's almost hitting to 1.2 to 2. All right, so it's pretty much high. Definitely. So this is definitely hitting and pointing you towards a very important case of acute liver failure. All right. So then what you do is that you you have you have these particular things that should come in your head. Obviously, first you should think about a viral cause as well. Okay. Now, if let's say this was something like a drug induced, it could be obviously drug induced. So you want to check if the patient is a TB patient, or you want to also check if he's an epileptic patient, or you also want to check if he's done accidental poisoning. Now, if this was accidental poisoning, it definitely would be like in 2 to 3 days. Also, you would get the entire thing, not 6 weeks. So we can definitely rule it out. But I'll just give you the accidental poisoning cases that you should think of. One is paracetamol, and the other is mushroom. You should think of and carbon tetrachloride. Okay, CCl4. But paracetamol, obviously, very very important, very very important. Okay, so basically he's gone up to almost 8 gram to 24 hour. If I give a patient scenario for a paracetamol poisoning, he would look like a 20-year-old medical student. uh, History shows anxiety, uh, less of involvement in studies, and certain issues. okay, and definitely brought to the hospital with severe acute liver disease, and you have a history of either paracetamol, straight up it'll be paracetamol poisoning, you wouldn't have anything else. Obviously you want to do charcoal management, you want to do charcoal, and you also want to give her N-acetylcysteine. I'm just putting this out there because we know that paracetamol can't be a scene out here in our case, where the male comes with almost symptoms that has begun 6 months ago. We ask him about any epileptic episode or any other drugs that is taking for epilepsy, for example valproic acid, phenytoin. He says no. We check if he's taking drugs for TB like isoniazid. He says definitely no. Isoniazid and rifampicin, they are really hepatotoxic. So that too is coming as a no. Does he have any UTI? Did he have any UTI for which he was taking nitrofurantoin? Well, actually, he says no. Okay, so then you obviously strike off the entire drug issue, so your drug is gone, completely eliminated. The second you want to also check is your virus, obviously, and in your viruses you want to keep in mind, mm, you want to keep in mind only two viruses. Actually, you want to keep A and E in mind. You can obviously keep B and C as well, but you want to keep A and E in mind. And if it's a pregnant lady, if it's a pregnant woman, you want to keep E in mind more. Okay, you want to keep hepatitis E virus in mind. Again, we'll go into viruses later. Let's also check at certain amount of toxins and poisons. All right. So if someone has ingested a rat poison, they can also come up with a severe liver failure. Rat poison. You also want to think of something like uh, diseases, certain diseases like Wilson, uh, tyrosinemia, galactosemia, galactosemia. Obviously, you want to think of alpha antitrypsin as well, alpha 1 antitrypsin deficiency. But all of this would definitely be seen in a child. It would come in more in a pediatric age group. So, again, our patient is around 20 to 20 years. So, again, I'm going to cross it off. Fair enough. Also, then you should check. Obviously, you want to also check for a very important condition that is called as HELLP, which is obviously seen in pregnancy. Pregnancy induced acute fatty liver of pregnancy. So again, this is not a pregnant lady, it's a 20 to 28-year-old man. Again, we need to strike it off. So now the only thing that's left for my diagnosis, first of all, is just by history, is thinking about viral infection. Now, if I really think about the viral infection, I want to limit my viral infection cases to two viral infections. All right, I want to limit it to two most viral important viral infections. All right. So I'm looking at A and E viruses. All right. And in A and E viruses, we need to understand that they are both transmitted by food, contamination of food. So obviously, as a doctor, you should know that if there has been an outbreak of hepatitis A or E, and if you know that there is an outbreak of hepatitis A and E, you definitely want to limit your diagnosis to hepatitis A and E virus. All right. So you want to think of hepatitis A virus and hepatitis E virus if you know there's been an outbreak. All right. So obviously, if that is the scene, then you should know that the incubation period is something like 30, 40, uh 50, 60. A, E, C, B. So you would have your symptoms for A in like around 30 days. For B, you would have it in around 40 days, an incubation period. Definitely. And if you want to diagnose it, obviously after, because he's presenting in like 6 months, you're more than sorted, or you're well established to do a diagnosis. So what you do is you do an IgM ELISA capture, okay, and you check for HAV antibodies or HEV antibodies. All right. Now the scene is that both of these antibodies come around at 12 weeks, and this is a little later than 12 weeks. A little later than 12 weeks, I could write around 12 to 14 weeks. All right. So around that time, you would definitely have these antibodies. Definitely, I'm saying that this could be acute liver diseases. These are acute liver uh, diseases. Can it lead to acute liver failure? Actually, it could, okay, uh, especially A in children and E in adults. but more commonly it would definitely be E. Okay, and let's say if it progressed to something like a fulminant hepatitis. Fulminant hepatitis is basically, it's not acute liver failure. Fulminant hepatitis is more intense. Why? Because fulminant hepatitis is more uh, with loss of clotting, complete loss of clotting. So you would have a lot of bleeding. You would have renal failure, very important. You would have ATN, you would have sepsis, very very important. You would have electrolyte abnormalities, you would have decreased sodium, you would have decreased glucose, uh, GI bleeds, cardiac arrhythmias, splenomegaly, one of the most important signs of decompensation, where your liver cannot compensate. All right. So your ALT. Okay. What about your ALT AST level? Very very important. I don't know how did I not forget to check it. ALT AST level is gonna be shooting out. It's gonna be shooting out. It's going to go in the census of 2003, 2000, 1000, that high. So you definitely want to keep that also in mind when you're doing a critical diagnosis. You also want to check for lactic acidosis level. You want to check for your acidic. You also definitely need to maintain your blood pH. It's going to be really really acidic, right? Because of loss of glucose, your entire gluconeogenesis is gone. So you will have an acidic pH. Your blood is also might show a little bit of acidic pH. So that is again something that you want to keep in mind when we talk about this entire case. All right. So that is again one case that I really wanted to speak about. So I think this is the case of acute liver failure that we have seen in a patient of 20 to 28-year-old. All right, and there's certain diseases, certain hints that the PT, hepatic encephalopathy, symptoms, disorientation, tremors are kind of hinting towards you that this could be it. Now let's take another case. So now you've diagnosed, definitely you see if he has HIV, and then you go forward and you treat for the same. So I will not get into that as well now. I'll go for another case. And we have a case that there's a 30 to 50-year-old female. All right, she's a female. And whenever the examiner puts on diseases like thyroid or your SLE, he's kind of hinting towards you that, you know what, you should start thinking in terms of autoimmune as well. Graves' disease, rheumatoid arthritis, anything. Okay, thyroiditis, grave disease, anything, rheumatoid arthritis. Okay, and she has had an history of chronic liver diseases. All right, she's had a chronic uh, liver failure. I can't say liver failure, obviously I can say chronic hepatitis, that's the right word to use. And now it has progressed completely into cirrhosis. It's seeming to be more like cirrhosis. Okay, so very bad prognosis. Okay, uh difficult to treat, very resistant to normal treatment, to your basic, resistant to usual treatment, like very resistant to spironolactone or any of those. Okay, your HEV, HBV, HCV, all are negative. So I'm telling you that we are ruling out the viral causes because this has progressed, right? So that means that this patient has definitely had a lot of scans. She has done a lot of blood tests. Okay, so obviously you pick it up and you think it's more of a uh, autoimmune. You start her on steroids and you see certain amount of absolute uh, reversal of this entire syndrome. So what can it be? Obviously, it is something that I don't even need to explain. It's autoimmune hepatitis, and see, the thing is, obviously, the patient is again going to come with the same clinical features as your hepatitis. He's going to have fatigue. He's going to have HS megaly. He's going to have, I mean, she is going to have uh, jaundice, um, pruritus, hyperpigmentation, because now it's going more into cirrhosis. So, yes, that is autoimmune hepatitis for us. But what would be to clench the diagnosis? If I really want to clench the diagnosis, I definitely need to remember that there are two types of HA, autoimmune hepatitis. One is your type 1, the other is your type 2. The one is your type 1, second is your type 2. Okay. In this scenario, if you want to figure out that what is the type, okay, sometimes you need to go into a transplant if the liver is decompensated. So you should know the type of the hepatitis, autoimmune hepatitis as well. All right. So obviously, what you do is that you check for antibodies. All right. So you check for antibodies, but which antibodies? One is that here you have to check for anti-LKM. This is something I remember very well. LKM antibodies. Okay. So anti-LKM antibodies in type 2. Okay. Liver kidney microsomal. Okay. And anti-LC antibodies. So the L's are in type 2. Now in the type 1, you want to check for smooth muscle antibody, anti-smooth muscle antibody, anti-actin antibody. And if this is there, bad prognosis. Bad. Okay. And Priyanka, you want to check for Priyanka, you want to check for ANA. You want to check for all of these. ANA again, because SLE association can be possible. Correct. Okay. So SMA antibody also. So this is another very important feature. You take a biopsy of this kidney, of this liver. What do you see? You see lymphocytes. Where do you see the infiltrate? You're gonna see it in zone 1. So this is your this is your hepatic vein. This is your portal triad. Okay. This is 1. This is 2. This is 3. This is zone 1. Where do you see the infiltrate? Any idea? Obviously in zone 1 only. See a zone 1 infiltrate. You also see something called as rosette formation, and a very important features is something called as an imperillosis. So basically what happens is that a phagocyte ingests phagocytosis without killing. So there is a cell inside another cell. Phagocyte is ingesting another cell. Okay. So okay, I think we've covered this entire scene of autoimmune hepatitis. Also, you will also have polyclonal expansion. So polyclonal expansion, you see, so when you do your electrophoresis, you will have your M band high, so your AG ratio will be also reversed. But that does not mean that you've gone into a infection or anything of that sort. Obviously, that is why you need to rule out your viral causes. Okay. I think that is us done with autoimmune hepatitis as well. The case. Well, actually, they can't give you much. You just need to keep in mind that SLE hai, diabetes hai, thyroid hai. So obviously, they are hinting towards one of these. Now there's another female. Okay, there's a female who is around 40 years, and she has extreme jaundice. She is associated with Sjogren syndrome. Plus, on your CT, you can see gallstones. But I won't say CT, I'll say she has a history of gallstones, because if you do a CT, it's very evident that you can diagnose this condition as well. That's another. She has a lot of fatigue. She has severe pruritus. She has pruritus. She has hyperpigmentation. She has xanthellamas. Okay. And she has an HM megaly, hepatomegaly. Okay. What do you check for when this patient comes? She has gallstones, she has fatigue, she has pruritus, uh, she may or may not have jaundice. So, what do you think that what could be the entire scene that we are looking at out here? Again, that I'm hitting towards your Sjogren syndrome. I'm telling you, she has Sjogren syndrome. Again, you should make sure that you've already started thinking in terms of autoimmune, 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 autoimmune. So I'll say, you do your ultrasound, okay? You do ultrasound and you check. What do you check? See, again, why I'm saying ultrasound direct. Or actually, you can do first your LFT. You can do your LFT if your ALP is elevated here. They show your ALP is elevated. They're saying it straight up. And they're also saying your GGT is elevated. Now, I am pretty sure that from basic biochem lectures also, we know that ALP and GGT both high means that there is an intrahepatic bile duct obstruction. Intra, extra, whatever. To rule that out, now we will do a CT. That where is the obstruction? Or first do a USG. Okay. You see that your intrahepatic duct is obstructed. And you can do a CT and you can go on. Okay. So that you need to keep in mind. Okay. So what do you think is this disease? Now you can see intrahepatic obstruction. Keep in mind that there could be secondary causes for intrahepatic obstruction, and you are ruling out drugs. You're ruling out any sarcoidosis, correct? You're ruling. So what do you come up with? You come up with primary biliary cirrhosis. Primary biliary cirrhosis. If you want to clench the diagnosis, for sure you check for AMA antibody. Here you'll have AMA antibody positive, positive, positive. Okay, so this is done. Once you have a AMA antibody positive, obviously your liver will be very, very palpable. Your liver will be palpable. You do not need to check for anything. Also, what you will have is that because bile is less in the GIT, you will have malabsorption. Your kida vitamins are gone. Your fats are gone. Okay. Second is that you will have a lot of gallstone. Why? Because your bile is not concentrating the cholesterol, so you will have a cholesterol gallstone. Correct. Again, you check for AMA antibodies. AMA antibodies will be positive. When you do your biopsy, the biopsy is going to show nothing but it's going to show that these bile ducts are going to be, the lumen is not going to be there. Correct. So the canals of Herring are also going to be lost. What are canals of Herring? Canals of Herrings are these spaces next to the sinusoids. Correct. Where the bile flows. Simple. And obviously you're going to also have a lot of ductopenia. That means decreased amount of ducts. Also what we could have is that we could see non-caseating granulomas. Simple. So now if you've cleansed the diagnosis so well by checking the AMA antibodies, by doing your biopsy, by doing your CT, what do you want to do? You definitely want to prevent the cirrhosis, right? Because this will eventually lead to cirrhosis. So what do you do? Simple. You do simple stuff. You don't do complex stuff. You do simple stuff. You do a ursodeoxycholic acid. Ursodeoxycholic acid, make sure it binds to bile salts and causing its excretion. Simple. Ursodeoxycholic acid. Cholic acid. Bile salt, you make sure it excretes. Your pruritus will also resolve. Everything will resolve. Because we are at PBC, there should be another topic that we should discuss is PSC, sorry. Here you're going to have intra and extra both. So let's say I gave you the same symptoms, but now on the CT and your USG, you can see both. And instead of a female, I'm saying a male. And I'm saying that the patient has ulcerative colitis. Okay, so it's a male. It's a patient with ulcerative colitis. Okay. Remember, this has an increased risk of cholangiocarcinoma. So next time when there is a case of cholangiocarcinoma, you can also think of this. Correct. Atypical P ANCA positive again. Atypical P ANCA. If we can clench the diagnosis here in atypical P ANCA, you should also think of atypical P ANCA being positive somewhere else also when it comes to the liver, and that is autoimmune hepatitis type 1. Correct. Okay. You do a PSC, you diagnose more by MRCP. Okay. And obviously on your histopath, the histopath was pretty basic. Here is something which is very characteristic: onion, skin fibrosis. All right. Wow. So I think that is another case that we have seen. Now you can check another case, and I'll give the disease first, and then we'll talk about the case also. That's something that we can also do. Okay. Patient comes to you. Patient comes to you. It's a child. It's not a patient also. It's a child. His hair is very kinky, copper dirty hair. Okay, neurodegenerative also. Okay, there are neurodegenerative signs. There is kinky hair. Okay, kinky hair. There is certain amount of tremors as well. There's tremors. Okay, very important. Very important is that you check the eye. You check something called as a KF ring. I don't even need to talk to you about it when I say KF ring. Okay. And I'm not saying a child also directly. I actually don't want to mention the age to be anything. Correct. But obviously it has to be less than 20 years. Less than 20 years. It does not mean very young, but definitely can be less than 20 years. And the moment I say the KF ring, Kaiser-Fleischer ring, even a kid is going to come and tell me about this is a Wilson. That's why I didn't want to make it any complicated. I didn't want to create any suspense. Second is that I see a sunflower cataract, which is on the posterior subcapsular cataract, which is a sunflower cataract. I'm pretty sure we've all learned it in the cataract in ophthalm. Very important is myotonic dystrophy shows a Christmas tree cataract. Okay, I hope we know that. I think sorbitol is going to also show certain amount of snowflake cataract, sorbitol accumulation. Myotonic dystrophy is probably by that. I'm trying to figure out which is the red oil. Red oil could be actually galactosemia, could be your that kind of a cataract. So you've got different types of cataract. Obviously, that we should also consider. Right, unnecessary. I'm writing it and making it complicated, but definitely sunflower cataract. Any third year student will also directly slap me and tell me that, bro, what are you saying? This is Wilson. Obviously, when I say the neurodegenerative signs, obviously I'm thinking in terms of dysarthria, okay, gait abnormalities, dystonia, gait abnormalities. Correct. So other manifestations that can be seen because of Wilson's pancreatitis could be there. Alright. So first, when you wake up as Wilson, then you check for other symptoms. Because as a medicine person, you have to check for other symptoms as well. So you check for type 2 RTA. Alright, type 2 RTA. I say always type 2 RTA is the one that involves the proximal part. Something like a Fanconi's is an example of type 2 RTA. Type 1 RTA is more towards the distal part. Both of them lead to hypokalemia. That's a different thing. Both of them can cause acidosis. That's a different thing. That's why it's RTA, acidosis. Large joint arthritis, you check for rheumatoid arthritis. You check for you check for anemias as well. Okay, you can check for that. But now if I'm asking you that simple box, you know what I do a LFT. What is my LFT going to show? It's going to show increased ALT, AST. Obviously, there'll be increased ALT, AST. It won't be very high. It'll be around a chronic level. That'll be less than 150. So it'll be around 50 to 100. Kiaspas. Correct. Your ALP is going to be low, which is showing that there is no obstruction. Correct. So what is going to clench your diagnosis? You want to clench your diagnosis by something called as ceruloplasmin. So your ceruloplasmin, your low serum ceruloplasmin is going to be low. It's clenching your diagnosis. You do not need to check. Less than 15 is suggestive. Okay. Less than 15, I'm saying it is Wilson's. Correct. You can also check your urinary copper. Urinary copper is a very good test. Urinary copper. Your urinary copper is more than 100. you're mostly thinking in terms of Wilson's. So then what do? You know that, the also you can do your hepatic tissue copper estimation. Basically take a biopsy, and the biopsy you check for how much copper is there. Okay. So also on biopsy, I like talking about biopsy a lot because it can become a pathological question as well. And sometimes pathology is the key to diagnosis as well. So what does your biopsy actually show? I'll tell you, it'll show ballooning degeneration. It'll show this very important very, very important body called as Mallory-Dane. It's going to show periportal hepatocytes are affected, zone 1, and it's going to show macronodular cirrhosis. Now, that is something that's very interesting to me. Macronodular. On electron microscopy, you're going to see tennis racket appearance of the mitochondria. Very important. So how do you treat it? You treat it simple. You do one very important thing. You do D-penicillamine. A first year student will also tell me, but the second year student will also wonder why zinc. You prefer this in pregnancy. What? You prefer what? You prefer zinc in pregnancy. Finish. Khatam. Okay. So we've seen all of these diseases. A lot of diseases we've seen. Alright? Teach.